I'd like to thank the organizing committee for inviting me to come to London and to speak to this conference. I will address the issue of respiratory features of aerotoxic syndrome. I'm going to very briefly present 3 real cases of aerotoxic syndrome with relevant respiratory symptoms. I hope this will give us the opportunity to review some of the ways in which aerotoxic syndrome may involve the respiratory tract. Let me begin by having a look at this slide. There's nothing surprising or new here, but this is an important journal. This is the official journal of the ATS, the American Thoracic Society. In this figure, we can see the targets of the respiratory tract that can be damaged by the exposure to organophosphates. There's a lack between the acceptance of the damage that chemicals may cause in the health or on the respiratory system and the poor number of published reports on clinical studies about long consequences of exposure to chemicals. There's a reason for that. In my opinion, most medical societies are reluctant to accept the existence of the syndrome. The lack of evidence, the lack of strict diagnostic criteria is the reason why these medical societies do not accept this entity. So we have to realize that it will be a challenging issue to try to change this point of view. Let's start off with the first case. This was a 47-year-old male international airline pilot who experienced 4 episodes of cabin air fume events over 2 years during flights on Airbus. 2 of them were smell episodes, and those 2 were smoke events of unknown origin. He complained about difficulties with immediate memory recall and occasionally with the fluency of his speech. After the last serious event, the pilot developed mild cough and shortness of breath that persisted for several weeks. His past history was non-remarkable. There were no prior medications and no other epidemiological hints. 1 month later, when I saw for the first time the patient, he presented with severe cough, productive of tiny whitish sputum, and moderate shortness of breath. On physical exam, there were bilateral wheezings, and the oxygen saturation was quite low, 93%, while he was breathing room air. He was febrile. A chest X-ray and a computed tomography scan of the thorax were normal. One of the options was a lung infection. That's why we carry out a microbiological workup. A sputum microbiology study was negative. Also, we ordered a polymerase chain reaction test to try to identify any of these viruses and other intercellular microorganisms that you can read here. The results were negative. We thought that we rule out the option of infection. According to physical findings on spirometry, we demonstrated a moderate airway obstruction with a strongly positive bronchodilator test. This was consistent with what is called bronchial hyperactivity. The infusion test was normal. We prescribed anti-inflammatory therapy with steroids and leukotriene inhibitors, as well as bronchodilator inhaled therapy. The patient improved slowly during the following 6 months, but neurological complaints even worsened. At 3 months of follow-up, a diagnosis of reactive airway dysfunction syndrome, also called RADS, related to aerotoxic syndrome was done. I know that most of you are not familiar with the results of pulmonary function tests. Don't worry, I will simplify it. You can see some of the abbreviations here. For example, TLC means total lung capacity, RV, residual volume, forced vital capacity, and so on. It doesn't matter. Please pay attention to the highlighted percentage column. All values above 80% are normal. All values below 80% are not normal. So the conclusion was that the patient suffered from a moderate airflow obstruction. On long-term follow-up, the patient complained about pain radiating down his arms and slight numbness and tingling in fingers. However, formal neurological examination was normal, blood tests were normal, immunological studies were normal, MRI of the brain and EMG were normal. A sample of blood was sent to Duke's University, and they demonstrated this high positive titer for anti-antibodies. I'm a respiratory physician, so I'm not very skilled on neurological disease. That's why I prefer just to focus on respiratory features of these cases. A few words about reactive airways dysfunction syndrome. Respiratory symptoms after exposure to irritant fumes, gas, vapors are usually cough, wheezing, shortness of breath, chest tightness. The onset of the initial description should be less than 24 hours after exposure and persist longer than 3 months. A documented absence of previous respiratory complaints is mandatory, and pulmonary function test has to show bronchial hyperactivity. It's interesting to point out that initially it was stated that a single inhalation of a high concentration of irritant was mandatory, but things have changed. I'm sure that everybody here remembers these terrible images. This was a terrorist attack that took place in New York 18 years ago. This attack provided some insight into our knowledge of rats. This author, Vanek, underlined that many people with a mild exposure to irritants also develop the reactive airway dysfunction syndrome. So since then, we know that rats does not require a clinically severe inhalation injury at the onset of the disease. So the concept has evolved to what is called low-dose rats, or low-intensity chronic exposure dysfunction syndrome. It's more related to irritant-induced asthma. And here, multiple exposures to low concentrations of irritants are accepted. The intensity of exposure is less, but may be of greater duration, and the onset of symptoms may happen after several hours or even days. Which factors play a crucial role in the appearance of the syndrome? Chemical and physical nature of the irritating agent, concentration, the possibility of simultaneous multiple agents, but we have to recognize that risk factors are incompletely characterized. When I talk about rats, there's always a question that raises from the audience. It's why some people develop the syndrome and why others remain healthy. I'm afraid we don't have a good answer to this question. Perhaps some genetic traits or some underlying diseases or medicines may make some people more susceptible to the development of the disease. Let's turn on the second case. This was a 34-year-old female international airline flight attendant who was exposed to a few repetitive smell oil odors in the cabin of Airbus during takeoff and landing for 2 weeks. Her past history wasn't remarkable. There was no prior medication, and she complained about non-specific upper respiratory tract irritation, a mild but progressive dry cough, and some skin itching. After the last strong odor episode, she developed a skin rash, particularly involving both ears and trunk. The cough worsened, and she began to complain about mild shortness of breath. You can see here these quite swollen and inflamed ears, and this quite impressive rash at the back of this lady. He didn't refer to any bite from any insect or tick when the appearance of the rash. Blood tests were normal after 2 days after the last episode, but serum cholesterol was high. It's important to point out that the eosinophils count was normal. This type of light set blood increases when there is an allergy or a parasite infection. The rash subsided after a course of steroid therapy, but moderate shortness of breath and dry cough and exercise persisted. A chest X-ray at the onset of the disease was reported to be normal. And 2 months after the onset, when I saw the patient, physical examination wasn't remarkable. A computed tomography was normal. And on spirometry, we saw normal values, but a strongly positive bronchodilator test, again, consistent with bronchial hyperactivity. Inhaled therapy was prescribed, the symptoms progressively subside, and the therapy was withdrawn after 6 months of follow-up. However, the patient continued to complain about anxiety and emotional instability. In my experience, this is a very common symptom in people that suffer from aerotoxic syndrome. Even she gave up working as flight attendant, and these patients are very reluctant to accept medicines because they feel that they are to some extent intoxicated or even poisoned by chemicals. So when we prescribe classical medicines, they don't like them. So I think that mind and body interventions could be very useful. In that particular case, it was very useful. The technique of mindfulness is a mental training that cultivates present moment awareness. Meditation practice is the cornerstone of mindfulness. And this non-pharmacological approach to psychological symptoms related to a variety of illnesses is a good option. In fact, mind and body interventions, such also Tai Chi or yoga, have been proven to be useful in other respiratory conditions, so why not in aerotoxic syndrome? There are some preliminary studies that suggest a positive effect of mindfulness meditation on cough reflex sensitivity, at least as you can see in this slide, in healthy volunteers. Let's move on to the third case. This was a 56-year-old woman, international airline pilot, who presented with symptoms of a long-term unbearable dry cough and upper respiratory tract irritation, always related to exposure to a variety of environmental normal substances or others. She also complained about recurrent headaches, relapsing inflammation of eyelids, pains in her legs and shoulders, weakness and tingling of her fingertips. The onset of symptoms was 9 years before, after a fume event on Airbus. Interestingly, 4 passengers also required medical assistance because of nausea and shortness of breath. When I saw the patient, on physical exam, there was a low body mass index, some skin abnormalities, and eyelids irritation. She presented with dry cough and deep breathing, and oxygen saturation was normal. A recent neurological evaluation was remarkable. Blood tests were normal, but again, a sample sent to Duke's University demonstrated an increase in this marker. Again, the value of this marker is beyond the scope of my presentation. Previous chest X-rays were reported to be normal. Spirometric values were also normal, but again, there was a significant bronchodilator response. Interestingly, the breathing of gas mixture used to perform the test, the diffusion test, induced a severe cough episode. So a diagnosis of multiple chemical sensitivity and bronchial hyperactivity related to aerotoxic syndrome was done. Cough improved with daily inhaled therapy with anti-inflammatory bronchodilator drugs, but non-respiratory symptoms persisted on long-term follow-up. In fact, the patient had been forced many years before to cease flying with obvious negative psychological connotations. A few words about multiple chemical sensitivity, also called idiopathic environmental intolerance. There are non-specific symptoms when the patient is exposed to low levels of chemicals, biological or physical agents. Medical societies are skeptical about multiple chemical sensitivity. In fact, they consider it is a psychiatric disorder. I think this is unfair. These people are suffering from serious complaints. I do not agree at all. It's unfair and even cruel. The reason is that there are no consistent objective diagnostic tests to define the illness, the same as may happen to some extent with aerotoxic syndrome. Cough is the most frequently reported respiratory symptom, and again, psychological approach is mandatory, and in particular, mind and body interventions. There are some tests that may help in the evaluation of multiple chemical sensitivity. The most known is the QESI or TIL test that was developed in the States. I don't think that to say that multiple chemical sensitivity and aerotoxic syndrome are identical. Let's see. This is a photograph that can be obtained on the web from the Spanish Association of Multiple Chemical Sensitivity. Okay? Please pay attention to the faces of these people. They wear masks. Some of these masks remind us of the First World War or the film The War of Galaxies. Some of them wear very dark glasses. So it's crystal clear, at least to me, that this is a very demanding photograph. It's quite easy to think that these people, perhaps, they are exaggerating their symptoms. We can compare that with this photograph that was taken from the Aerotoxic Association a few years ago. It makes a difference. If you look at the attitude of these people, you will realize that these men probably are not very healthy, but they are proud of being captains. And probably they are willing to fly again as soon as possible once they have recovered from his illness and they have recovered their stamina. Okay? So I finished my presentation with these conclusions. Respiratory symptoms rank second to neurological symptoms. Respiratory symptoms have been often neglected since many clinicians are unaware of this condition. I think that's a very important point. Bronchial hyperresponsiveness is the hallmark of respiratory involvement. Some cases are consistent with reactive airway dysfunction syndrome, also called irritant-induced asthma, and some cases may also be included in the spectrum of multiple chemical sensitivity or idiopathic environmental intolerance. It's been my pleasure to be here. Thank you very much for your attention.